Hello everyone. Today I'm here to discuss everything about pulpectomy. So what is pulpectomy? Pulpectomy involves complete removal of necrotic pulpal tissue from the root canals and coronal portion of non-vital primary teeth to maintain a tooth in the dental arch. The indications for pulpectomy include primary tooth with irreversible pulpitis, a tooth treatment plan for pulpotomy in which the radicular pulp exhibits clinical signs of irreversible pulpitis, pulpal necrosis, roots should exhibit minimal or no resorption, and non-vital radicular pulp with or without associated infection. The contraindications include gross loss of root structure, advanced internal or external resorption, periapical infection involving the crypt of subcutaneous tooth, patients with systemic diseases such as congenital or rheumatic heart disease, leukemia, and children on long-term corticosteroid therapy or those who are immunocompromised. Less than two-thirds of the root length remaining is another contraindication, and perforation of the pulpal floor. So what is the procedure for pulpectomy? It can be divided into two, complete or partial. Complete involves two-visit non-vital pulpectomy, and partial includes single-visit partial vital pulpectomy. As you can see in the image, pulpectomy involves complete removal of the pulpal tissue from the coronal portion of the pulp also, and along with that, radicular portion of the pulp is also removed. Coming on to the procedure, a one or two stage pulpectomy may be undertaken depending on whether the radicular pulp is irreversibly inflamed or non-vital. If infection is present and the presence of an exudates does not allow drying of the canal, consideration should be given to the two-stage pulpectomy technique, where the root canals may be dressed with an antimicrobial agent for 7 to 10 days and subsequently obturated at the second visit. This is the procedure for pulpectomy in the clinics. Firstly, local anesthesia is given. Second step is to place the rubber dam. The third step is to remove the carious part. And the fourth step is to remove the coronal pulp. As you can see in this image, the access opening has been done, showing the openings of the root canals. Once it is done, files are taken into the root canals and removed, and the remaining pulp is removed from the root canals. Followed by working length determination. Working length determination can be done by various methods. The most commonly used working length determination is the radiographic method, wherein the files are placed at the length where they get the maximum resistance, and the X-ray is taken. X-ray can be taken in the form of an RBG or a normal intraoral periapical radiograph. Followed by that, irrigation is done, and the tooth is obturated with a biocompatible material. Now, in this image, it is shown that complete debridement of the pulp has been done, and the pulp chamber along with the root canals are looking clean, which is followed by obturation. Now, this is the preoperative X-ray of one of the cases that have been performed, which shows the caries extending into the enamel dentin and pulp with a radiorecency in the percussion area. This tooth is indicated for pulpectomy. The other radiograph shows the 6 months follow-up after pulpectomy and giving stainless steel crown. As you can see, the bone formation has been occurring, and the lesion has decreased tremendously. So what are the ideals for endodontic access? A complete removal of pulp chamber root has to be done. Complete removal of coronal pulp. Straight line access to facilitate placement of endodontic instruments on obturation material. These ideals are balanced with the following constraints. We also have to conserve the tooth structure. Retention and aesthetics have to be maintained, and final restoration has to be given. Like I mentioned, the working length determination, which is the first step of pulpectomy, is done by various methods, which can be conventional method for accuracy, conventional X-ray method, intraoral distal radiovisuography, tactile perception, coverage with lens, paper points, and apex locator. The biomechanical preparation is the second step, which involves the use of K files and H files, and also sometimes, um, in fact, most of the time these days, rotary systems are being used, like M2, flow taper, or neo files. Mostly 4% taper is preferred for primary teeth. Also, lasers and hard tissue lasers have been used to biomechanical preparation for pulpectomy. The procedure involves with an endodontic file, the diseased pulp is removed from all the canals. The canal should be instrumented to the resistance point. Each canal should be enlarged 3 to 4 instrument sizes greater than the first file capable of working the apex. After filing, the canal should be irrigated and then dried with cotton pellet or paper points. Going on to the irrigating materials form a major chunk of biomechanical preparation because they are the ones which are responsible for removing the pulpal tissue in the areas where the files cannot go. So the other properties of irrigating materials include tissue and debris dissolution, low surface tension to promote the flow of irrigant into the inaccessible areas. Lubricant property enables instrument to readily slide down the canal. Sterilization, removal of smear layer should be less costly or cost effective. Adequate shelf life should be there and ease of storage. Most common irrigants used in pulpectomy procedure include saline, sodium hypochlorite, EDTA, which is 10%, 6% citric acid, 2% chlorhexidine, and Kerry salt. Now we go on to the need for removal of smear layer in pulpectomy. It is to enhance the antibacterial action of the irrigants, to reduce the microleakage, for better adaptation of paste to the dental walls. Smear layer is basically a layer which is formed after preparation of the tooth surface, which also contains the bacterial component. So to have a successful treatment, it is important to remove the smear layer. Going on to the root canal obturating materials for primary teeth, the ideal requisites include they should not irritate the periapical tissues, should not coagulate any organic remnants of the canal, should have a stable disinfecting power, dissolve at a similar rate as the primary root, should be easily inserted into root canal and removed easily if necessary, should not be soluble in water, should be radiopaque and not discolor the tooth, and should adhere to the walls of the canal and should not shrink. Some of the examples for root canal obturating materials include camphorated parachlorophenols mixed with calcium hydroxide, CPC mixed with zinc oxide, formicrosol mixed with zinc oxide eugenol, chlorhexidine mixed with zinc oxide eugenol, zinc oxide eugenol itself, zinc oxide mixed with sterile water, calcium hydroxide with sterile water, iodoform, diapaste, Frank's paste, Maestro paste, Leonardo's paste, Walkoff paste, Vitapex or Metapex, Pulkit, RC Film, Endofloss, Endoseal, Zydose Pinto paste, WMPA, calcium oxide, octacalcium phosphate, and the list goes on. But the most commonly used are zinc oxide eugenol, Vitapex or Metapex, and these days Endofloss. Now, before I go on to discussing different obturating materials, I'll be showing you the pulpectomy procedure so that you get a hang of how it is done in the patient's mouth. First of all, the access opening is done with the round ball. Local anesthesia has to be administered before doing access opening. Then a 50 number file is taken and taken up to the working length. In this case, arbitrary working length has to be measured by the method of average working length. Now a series of files will be taken along with irrigation with saline. Like I mentioned, you can use sodium hypochlorite as well, but it's better to use a rubber dam in that case. Now, rubber dam is necessary for isolation, but in this particular case, there was hardly any construction for its retention. That's why suction was used to promote aspiration. Now, once the pulp is removed with 15 number K file, a series involving 20 number K file, 25 number K file, 50 number file, 35 and 40 number K file is used to do biomechanical preparation of the pulp. Along with that, irrigation is done in between each instrumentation to remove the tissue. Irrigation forms a major component because without irrigation, there won't be any lubrication for the files and it can break in the root canal. And also, they remove the irrigants, cause disinfection, and remove the remaining pulp tissue as well. Paper pulps are being used to dry the root canal before oxidation. Drying the canal is a very important step which allows the sealer to flow through easily into the root canals, and all the irregular areas present in the root canal. Now, once the bleeding is controlled or the canals are dried completely, oxidation will be taken off after this. Now, as you can see, in this patient, Metapex is being used for filling in the root canals as an oxygenating material. The advantage of Metapex over other materials is that they have an antibacterial effect as it has calcium hydroxide. Also, it removes any infection along with removing any infection. They also promote inflammation and healing of the tissues. Thirdly, since it is in a paste form, it is easy to flow through. Fourthly, if the Metapex extrudes beyond the apex, it gets resolved easily after 15 days or so. A small saline wrapped cotton is used to push the Metapex upwards into the canals. And with Metapex, incremental filling technique is used. As you can see, the child is quite comfortable with the procedure. That's the most important thing for a pediatric dentist. If the child is uncooperative, then the procedure is always comfortable. Now, once the oxidation is done, the filling is given over the axis of length area to close it and prevent any reinfection from happening by preventing any ingress of microorganisms or saliva. The filling should be done properly so that the margins are approximated with the so that when the filling is set, there are no irregular areas from where the microorganisms can enter into the tooth surface, into the pulp canal. So coming back to the type of obturating materials we use in the clinics for pulpectomy. Let's start with zinc oxide eugenol. It was discovered in 1837 by Demonstrat, and it was subsequently used in dentistry by Tiscombe in 1876. Zinc oxide eugenol pays for the first root canal filling material to be recommended for primary teeth as described by Sweet in 1930. The success rates were reported after obturating zinc oxide eugenol cement by various authors, and which are as follows. It ranges between 82.3% to 86.1% by different authors, which is a quite high success rate. Though it is the most commonly used root canal filling material for primary teeth, has an antibacterial effect, but overfilling causes a mild foreign body reaction, so we have to be very careful in not pushing it beyond the apex. Also, the rate of resorption is slower than that of primary tooth root, which can sometimes delay the eruption of a permanent tooth. It also has an anti-inflammatory and analgesic effect. Going on to calcium hydroxide paste, the introduction of calcium hydroxide was done by Homan in 1920. It promotes healing in many clinical situations, and the success rate ranges from 80 to 90%. Now, when calcium hydroxide is placed inside the canals which are not dry and has blood in them, it promotes internal resorption, thus decreasing the success rates in those cases. Also, alkaline property of material was said to counteract the inflammatory process by acting as a local buffer and by activating the alkaline phosphatase activity, which was important for hard tissue formation. The depletion of the material from the root canals was found to be main disadvantage of calcium hydroxide as root canal filling material. So after some time, maybe 6 to 7 months later, when you will take an X-ray, you will observe that it has dissolved. Other material are Franks paste and iodoform or tri-paste. Franks paste contains calcium hydroxide and CPC. It is well tolerated by adjacent periapical tissue without any inflammation and with deposition of osteodentine. Iodoform or cry-paste contains iodoform 80% roughly, camphor 4.86%, pyrochlorophenol 2% roughly, and menthol 1.2%. It resorbs rapidly and has no undesirable effects on subcutaneous teeth. The material extruded into periapical tissue is rapidly replaced by normal tissue. It has superior antimicrobial action and does not set into hard mass and can be removed if retreatment is required in case of reinfection. Going on to Gattapacha. Now, Gattapacha is not usually used for pulpectomy procedures since it is non-resorbable. It is only used in those cases when the roots of the primary teeth are completely present and there is absence of the subcutaneous tooth bed. Workhoff paste is a mixture of pyrochlorophenol, camphor, and menthol, and Meister paste contains zinc oxide, iodoform, thymol, chlorophenol, and camphor, along with lanolin. Going on to Vitapex, it is one of the major operating materials that is being used worldwide. It contains calcium hydroxide, 40% iodoform, and silicone oil. It is nearly ideal material for filling primary root canals. The mixture is easily applied, resorbs at a slightly faster rate than the primary tooth root, has no toxic effect on permanent successors, is radio opaque so that it is easily observable on X-ray. Iodoform is a known bactericide that is released from the sealer and suppresses any residual bacteria in the canal or periapical region. Iodoform containing pastes are easily resorbed from the periapical region, thus causing no foreign body reactions, and overfilling and resorption of the paste containing iodoform from the root canals had no effect on the success of the treatment, but regarded as having a positive healing effect. This is a comparison between different commonly used obturating materials in primary teeth. Now, if between zinc oxide eugenol, Vitapex, and dry-paste. So, if we come on to the rate of resorption, zinc oxide eugenol resorbs slower, and Vitapex has a slightly faster resorption rate. Dry-paste also has a faster resorption rate than the paste. None of them causes toxicity, and resorption occurs in all, but the rate depends on different type of contents that are present in these materials. Antiseptic action is present in all. Application is easiest for white effects, and all of them adhere well to the root canals. Removal is also easy. All three of them are radiopaque so that they can be observed easily on the X-ray. Now, the Guides Pinto paste contain Rifocort, which is corticosteroid, along with camphorate, parachlorophenol, and iodoform. Now, this was the first material which had steroids in them, and because it had an anti-inflammatory effect along with antiseptic effect. It reduced the amount of inflammation in the area and promoted healing. Going on to endofloss. Endofloss is another recent material that is being used for obturating the primary root canals. It contains triiodomethane and iodine, dibutylol, orthocresol, zinc oxide, calcium hydroxide, barium sulfate, and liquid consisting of eugenol and paramonochlorophenol. It is hydrophilic, that is, it attracts water, and can be used in mildly humid canals. It firmly adheres to the surface of the root canals to provide a good seal, has a broad spectrum antibacterial activity, is biocompatible, and can be removed by phagocytosis, hence making the material resorbable. Unlike other pastes, endofloss only resorbs when extruded extraradicularly but does not wash out intraradicularly. So this is a positive point which gives it an upper hand than white effects. The disadvantages include eugenol contained can cause pericardial irritation, with discoloration can happen, and endofloss may be successfully used for root canal treatments in primary teeth, particularly if care is taken not to overfill. It is a very successful material. Going on to MTA, now like Gatta MTA is also used as an operating material for pulpectomy in cases when there are no permanent successes. Going on to calcium hydroxide, filling endodontically treated teeth with calcium oxide produces clinical results that are indistinguishable from conventional methods without incurring an excessive rate of root fracture. With the addition of yttrium oxide, calcium oxide can be made radiopaque to an acceptable degree. Calcium oxide should be considered a safe and viable alternative to other current methods of root obturation. Ledomix, another material for obturating the root canals. The composition includes triamcinolone and demeclocycline. Now again, Ledomix has a combination of corticosteroids to reduce the inflammation in the area of concern. Root filling with Ledomix paste also resulted in significantly less loss in root mass due to resorption compared to those used with the calcium hydroxide. While assessing inter-appointment pain in both the groups, statistically significant difference was observed at 48 hours after initial treatment in favor of Ledomix paste. Therefore, it is a good choice of intracanal medicament. Now, coming on to the obturation techniques, there are different obturation techniques that can be used. It includes incremental fill technique, Lenchulo spiral technique, endodontic pressure syringe technique, Navitip or Navitip system, tuberculin syringe, and local anesthetic syringe, which can be used for filling. Now, coming on to the incremental fill technique, in this case, this technique is used for zinc oxide eugenol. In this, thin mix of zinc oxide eugenol is used to coat the walls of the canal, followed by a thick mix condensed into the lumen. Endodontic plugger, a small amalgam condenser, is used to compact the paste at the canal orifice. Now, when the canal is assumed to be completely filled, a wet cotton pellet is used to lightly tap the material into the canals. So, the next technique is Lenchulo spiral technique. Now, Lenchulo is an instrument which is used for obturating the materials. Lenchulo instrument is one size smaller than the last size file used for root canal preparation. Mix of zinc oxide eugenol is done as a slurry, and the Lenchulo is pinned into the root canals using the spiral root canal filler. Now, another technique is pressure syringe technique. It is a syringe which is developed by Pulkit. Firstly, the root canal determination is done and the root canal preparation is performed. Syringe size is taken according to the biomechanical preparation or the master cone size. This is according to the chart of instruments and needles given. So on the left side, it mentions the file size of the apical area, uh, that is 1 to 2 mm apical area, and the corresponding pressure syringe needle gauges required for obturation. Once the material is mixed, this is the needle that is being filled with the mixed material, which will be pushed into the root canals. Now, while the needle hub with fill the needle hub with sealer. Now, this is the procedure for doing that. You have to mix the material and fill it in the pressure syringe and insert the screw plunger. The material will start flowing out. Now, once you put the needle into the root canal, you have to pull out the needle from the root canals while filling it in the apical direction. The latest material used for obturation is Navigative. It is by Ultrarin. They provide controlled delivery to the apex. They are flexible, stainless steel cannula easily navigates curved canal, and it is available in 17, 21, 25, and 27 millimeter lengths. And 29 or 30 watt cannula is also available for decreasing the length, decreasing the diameter of the needle so that it reaches the apical area easily. Now, a similar technique is used with disposable injection technique. The material is mixed and placed into the disposable injection with a needle which has a wider diameter. Now, once the obturation is done, the tooth is uh, uh, covered with a final restoration, which can be in the form of composite restoration. The ideal restoration, which is done after pulpectomy, is the use of a stainless steel crown or a full coverage restoration in the form of a zirconia crown or acrylic crowns, which is necessary to prevent the breakage of the tooth and prevent reinfection. Now, once we have done the pulpectomy procedure, it is also important to judge and analyze the success of our treatment. So, post-operative follow-up is done at 6 months interval for medium and low risk patients, and 3 months follow-up is done for patients who have high caries risk. When the patient comes on follow-up, the things that we check for evidence of failure is pathological mobility, presence of fistula, of pain on percussion. All these signs show that there is clinical failure. And on radiograph, there should be increased size of radiolar sensing or external or internal resorption, showing that the treatment is going towards the failure. Now, the eruption of permanent successor should always be on our mind. Non-vital teeth treated with pulpectomy. Premature root resorption is more marked. The filling material is not the same texture or hardness as normal tooth. When the erupting permanent successor meets the root canal filling material, there is increased possibility of deflection, like I mentioned, especially in cases of zinc oxide urion, as the material does not resolve at the same rate as the tooth. Thus, to conclude, the main purpose of pulpectomy procedure is debridement and removal of microorganisms from the root canal. The extent to which this is done determines the success of the procedure. An increase in success rates have been observed with the use of new techniques and materials being used for biomechanical preparation, irrigation, and obturation of the root canals. The research is needed to devise methods for 100% sterility of root canal before obturation for a successful pulpectomy procedure. Thank you. Thank you for your patient listening, and I hope this lecture would be of help to you.